14 topic to be discussing. So next slide. Next slide. So the first topic is cataract. So cataract by the definition is an opacification of the eye lens that cause reduce in visions. So briefly about the anatomy. So lens are located posterior to the iris and anterior to the vitreous chamber. The characteristic of the lens is transparent, biconcave in structure, and enclosed in a thin capsule. So the functions of the lens is to transmit light and focus it to the retina, and also for accommodation, which when we look at the near or distant object. If we want to look at the near object, the lens will relax, so it will become spherical in shape. Zonular tension will decrease and ciliary muscle will contract. So contrast in for distant vision, the lens will be flattened and the zonular tension will be increased and ciliary muscle will be relaxed. So there is lots of causes for cataracts. So one of them is congenital, which we can get from familial or from the intrauterine infections. And most commonly, cataract is caused by aging, which most common occur in elderly. And there is a metabolic causes such as diabetes mellitus, and other causes such as drug-induced traumatic or inflammatory can cause cataracts. Next. So this is a brief pathophysiology about the cataracts. So any altered metabolic process in the lens such as oxidation stress, metabolic disturbance, toxins, membrane destruction or reduced metabolism, all of these can cause reduction in oxygen uptake. And this will cause increase in water content followed by dehydrations, and will cause denaturations and abnormal changes to the lens crystalline protein, and this will cause increased density, stiffening, and pigmentation of the lens, and will lead to opacifications of the lens. Next. Next slide, please. Okay. So there is actually lots of types of cataracts. We can divide it based on the time of occurrence, congenital or acquired, anatomical position of the opacity, such as in this slide, and we can also classify by the degree of maturity. So for the more anatomical position of opacity, we have cortical, nuclear, and the posterior subcapsular. So in cortical cataract, it will begin as whitish wedge-shaped opacities or streak in the outer edges of the lens cortex. So as it slowly progress, the streak will extend to the center and will interfere with the light passing through the center of the lens. So the fissure will cause a light to scatter when it hitting the retina and often causing issue with glare. The second one, nuclear. So the nuclear the cataract develop at the center of the lens. So the center of the lens will become hardened and yellowish in color. So there is a most common type of cataract and will progress gradually. And they generally affect focus and in some cases may cause a temporary improvement in close-up visions. So the third one is subcapsular, and the most common is posterior part. It occurs at the back surface of the lens and inside under the lens capsule, and they often will cause a reading issue, light sensitivity, glare, and halos effects. So next. Next slide. Next is based on the maturity of the lens. So we have 4: immature, mature, hypermature, and Morganian cataract. So in immature, the lens will be partially opaque. Compared to mature, the lens will completely opaque. In hypermature cataract, the lens will shrunken and wrinkle at the anterior capsule due to the leakage of water from the lens. In the Morganian cataracts, it is hypermature cataract in which there is a liquefaction of cortex has allowed the nucleus to sink inferiorly but within the lens. So next. When people have cataract, they will present it to clinic or hospital by a complaint reduced in visions, it a near or distant object. And also they will have a glare. Maybe they will complain that they cannot drive during the night because macam silau, they cannot see the lights. And also there is loss of contrast sensitivity and loss of ability to discern color, such as when they see a white color, they perceive as yellowish color, and all of these symptoms is not associated with any pain, redness of the eye, and discharge. When we do a any examination, we will be explained by Azima later. We can see there is a reduce in visual acuity and diminished red reflex, as you can see in the picture below. So at the right eye, we can see the red reflect, but the left eye, we cannot see the red reflect. So this is another characteristic of the cataract. So that's all from me. I will pass the presentation to Azima.
All right. Can I just give a quick comment? Excellent presentation, by the way. It's just the ultimate function of this lens will be to give a refractive power to this, to the eye, to give a proper focus of the image, just like you mentioned. And then, according to the types, you can add some more types, something called intumescent cataract, which is the lens will become more thickened, and it can cause some lens-induced glaucoma sometimes, where the thickness of this lens can lead to the shallowness of the aqueous chamber and narrowing of the angle, and then the intraocular pressure can increase. And then something else called the brunescent cataract. So you did mention about the pathophysiology and then the turning out of this lens to be yellow, and then it can turn to be brownish sometime. That's just some comments. Okay, the next presenter, and then please try to be fixed with 5 minutes. We did consume more than 5 minutes already, but for the next presenter, try to be as quick as you can so we can continue with all the topics within 1 hour. Right, thanks.
Okay. Okay, now for my part. Okay, next slide. Okay, for the next, for the investigation to diagnose the cataract, well, of course we need to look for the history because it is most commonly related to the age, and also for the complaint, for look for the clinical finding, and also ask for the family history regarding of the cataract. And also we need to exclude other causes too. And then for the examination, why we need to do the visual acuity? Because there is a reduced vision in this cataract patient. Okay, so first of all, we start with the distance vision first. As usual, we use the Snellen chart. And then if patient still could not see, we use the counting finger. And then if patient still could not see, we use the hand movement. And also maybe if patient still could not see with hand movement, we use the perception of light. Okay, and then we test for the near vision. Also to in the visual acuity, we must state whether it is unaided with glasses or using the pinhole. If after using pinhole, the vision is doesn't change, there is no refractive errors associated with it. And then for the ocular examination, also we need to inspect. So in the cataract, they have corneal opacities. And then we assess for the pupillary assessment, like direct concentric swinging light test, if there any damage to the optic nerve. But usually, okay, and then visual field confrontation, and also we do the fundoscopy to check the red reflex. So in this cataract patient, the lens is opaque. So when we shine the light into the lens, it doesn't have a red reflex. It doesn't show the reflection of the vasculature of the inner part of the eye. Okay, and for the slit lamp examination, basically we want to measure the anterior chamber depth, and also we can classify the types of the cataract based on this examination, and also grading. And for the other tests to do, we can do the glare test and contrast sensitivity test, because in this patient, they have reduced insensitivity towards the contrast that they don't even realize. So we want to measure that. And also we can do B-scan ultrasonography to, as we can see, as usually we use the fundoscopy to see inside the retina, but since this is blocked, we can use the scan ultrasonography. And for the keratometry, it's basically because we want to measure the corneal curvature and corneal power. Because usually in management of the cataract, there's no medical treatment and usually surgery. So we use the implantation of the artificial lens. Okay, and then for the other blood investigation, we need to do also if there is systemic disease causes that is suspected. Okay, next slide. Okay, this is
Or there is something called A scan.
hmm?
Have you know about the A
What
scan? Have you heard about the A scan?
is can no doctor.
Right. A scan is necessary to give you the expected power of your artificial lens, and then it will give you all the parameters that you are looking for, which is the depth of the AC, the thickness of the lens, the keratometry, and all that. So you can add one of the investigations, which is so much important, A scan. All right, you can
Okay.
continue.
Okay, this is just the example. Okay, next slide. Okay, this is actually we want to as we know the type include nuclear, cortical and post-subscapula. If the nuclear you can see from the eye there is a yellowish brownish deposition, and then for the cortical there is spoke opacity, which actually like a bicycle like appearance, you know, bicycle rim, from the periphery towards the central, and then for the post-subcapsular, as you can see, it is posterior to the capsule of the lens, so it is you can see it is deeper at the picture below. Okay,
Right. And
next slide.
so just
Okay.
refer to these pictures, but you don't say posterior to the posterior capsule. It's not like that. It's a subcapsular, which is in front of the posterior capsule, but
Okay.
behind your nucleus, and behind,
Mm.
let's say, in the posterior cortex of the lens. But refer to these photos and you can know the gradings. Okay, anything else with the cataract? Next slide.
Uh, Actually, there's about the slim. Okay, okay, next slide. Next slide. Okay. This is actually the grading for just what I know.
Right. It's
This I actually I'm not so
right.
sure. Okay. All right.
That's all right. Just refer to
Okay.
these photos as the grading. And
Mm-hmm.
we just know that there is something called cortical or nuclear or the PSCC, the posterior subcapsular cataract. Okay,
Okay.
next.
Okay. Next slide. Okay, and then for the treatment, as usual, we actually no really effective medical treatment. Cataract surgery is the only way to replace with the artificial lens. Okay, cataract surgery will later be present by other people at the end of the session. Okay, I think that's all from me. I will pass to the
Beautiful.
next
Okay,
presenter.
next
Thank you.
speaker. Okay, all right. Thank you very much. Excellent presentation. So the next presentation will be corneal abrasion. Okay.
Okay, I'll now proceed with corneal abrasion. Next slide, please. Okay, corneal abrasion is a disruption in the integrity of the corneal epithelium, or because the corneal surface is scraped away as a result of physical external forces. As we know, the cornea has several layers, and the epithelium is affected in corneal abrasion. So the potential causes of corneal abrasion are such as injury from fingernails, paper, and mascara brush. For example, when we're rubbing our eyes with our hand, and we can accidentally injure it from our fingernails, blowing dust, sand, or debris, extended contact lens wear. Contact lens induced epithelial defects or direct trauma usually happens during lens removal, where sometimes a person's fingernails may slice the contact lens and accidentally injure the cornea as well when trying to remove it. Or sometimes, if a person is wearing a contact lens for too long, the lens tends to become slightly dehydrated at the end of the day due to insufficient blinking. So it causes the lens to stick to the cornea. So while we're trying to remove the lens, uh, the epithelium comes together with it. So the epithelium may not heal well, especially if the epithelial cells are continuously torn away due to contact lens. Then dry eyes. People who work in dry environment, read most of the day, or look at TV or computer screens for most of the time during the day may have dry eyes, and dry eyes is could be one of the cause for corneal abrasion. And lastly, ultraviolet burn or chemical exposure can also cause corneal abrasion. So, as for the symptoms of corneal abrasion, patients with it typically complain of eye pain and an inability to open the eye because of foreign body sensation. So, usually they'll feel very uncomfortable to work, drive, or read. They can also complain of pain, watery and red eyes, photophobia, blurry and decreased vision, and eye twitching. So the symptoms typically they begin instantly after the trauma occurs and can last minutes to days depending on the size of the abrasion. Also, the clinical presentation is usually unilateral when the corneal abrasion is associated with trauma, or it may be bilateral when it is associated with UV burns or chemical exposures. Next slide.
Okay, so hello everyone. I'll be continuing on the diagnosis and the treatment for corneal abrasion. My name is Swarna, and I'll try to make this as short as possible. So, as for diagnosis, first of all, one of the main procedures done is by fluorescence staining, and this is to reveal the abrasion under the blue light. So basically, fluorescence stain is orange color type of dye, and then it usually after you apply it on the eye, it will pass over the normal corneal tissue lah. And then wherever there's a defect, it will go and get stuck into that area only. So under white light, it's not usually the first thing is not really visible. So we have to put a blue color light in order to see where exactly is the defect. So under the blue light, the staining it will become green in color. As we can see in the picture below, the first one we can't really identify where exactly is the dye when it's stuck. But then after the blue light, we can see that it's near the pupil, and also at the bottom eyelid, we can see a bit of the stain there. Okay, so as for management, our aim is to number one, ensure healing of the abrasion. Number two, prevent infection and also to relieve pain due to the corneal abrasion. So we can divide it. The treatment is divided based on the size or whether it's uncomfortable to the patient or not. So for a small type of corneal abrasion, we give them this current penicle ointment or in the form of eye drop as well. It's a type of antibiotic, and if it's an ointment, we ask the patient to put it 2 times per day. If it's an eye drop, we ask them to put it 4 times per day. So even though the ointment is said to be better than the eye drop, it's because it usually gives a long-lasting type of lubrication to the eye compared to the eye drop. So like because of the long-lasting lubrication, it not only prevents infection, it can reduce the discomfort in the patient and simultaneously promotes healing. Okay, as for large or uncomfortable type of corneal abrasion, we can advise patient to do double eye pad together with the chloramphenicol ointment. So this double eye pad is to basically is to keep the eyelid from moving too much since it's uncomfortable kan. So this double eye pad it has to be firm enough so that the eyelid does not move, so it can reduce the uncomfortableness. Okay, so usually this iPad and this together with the chloramphenicol ointment, we ask the patient to put for like around 1 day or until the symptoms improve. But if the iPad is not comfortable to the patient, then we remove it and just administer the chloramphenicol ointment only. And then as for the pain, we can also give them this cycloplegic eye drops, which is the function is basically to paralyze the ciliary muscle, so there's not much movement lah, and we can
Okay,
type of yes,
nice. All right. So instead of saying chloramphenicol per se, you can say the broad term, which is antibiotics, and do not be fixed on chloramphenicol. That's one. The second thing will be lubrication, which can include a lot of types of lubricants. And we can sometimes use the bandage contact lens, which is also helping in the lubrication. and the double eye padding sometimes can be used. So instead of being fixed to this type of antibiotics, you can just say the broad term of antibiotics. The thing that I wish that you guys also present was the mechanism of corneal healing, corneal epithelial healing, and the corneal healing in general. So we do depend on something called the limbal stem cells, and we do need a healthy limbal stem cells for this healing to occur normally. So eyes that have limbal stem cell failure will have difficulty in healing of the corneal abrasions or the corneal healing in general. Okay. So anything else? The next slide. Do we still have another slide, or that's it?
That's
We
it.
can start. Okay, excellent,
Uh,
excellent. Okay, the next.
for
Yeah.
corneal abrasion. Yeah. Hello. Yeah. Continue.
Yes.
Yes,
Hear me.
doctor.
Yeah. That's all right.
For
Yeah,
corneal
you're saying?
abrasion, you expect the corneal healing epithelialization for how many weeks? I mean, re-epithelialization start usually, see the size lah, usually 1 to 2 weeks, okay? So when after the healing, the cornea, sometimes they can have a the corneal abrasion will recover because of desmosome not strongly attached. So usually the attachment of desmosome is around 1 year lah, up to 1 year lah. So some of them they can have a recurrent corneal abrasion. And in this corneal abrasion, the most important one is like what Ali said, is the limbal stem cell. So it usually happen in all those chemical injury lah. So chemical injury, you must be very careful lah for this case. And you need to differentiate how to differentiate corneal abrasion with ulcer also lah. So if ulcer, there's infiltrate. If abrasion, there's no infiltrate. Okay.
Okay, thank you, doctor.
Okay, let's move to the next presentation. Thank you very much, Owen.
So I will proceed with the corneal foreign body. And so next slide. So for the pathophysiology, the corneal foreign body usually involve the metallic, glass and organic material foreign body that following the wound injury. So this small particle may become locked in the corneal epithelium or the stroma. And then the foreign body may stimulate the inflammatory cascade, causing dilatation of the surrounding vessel and subsequent edema of the lids, conjunctiva and cornea. The RBC also may be liberated, resulting in an anterior chamber reaction and or all corneal infiltration. So if the foreign body not removed, it may cause infection or tissue necrosis. So for the sign and symptom, usually patient will present with the pain, foreign body sensation, photophobia, tearing of the eye and the right eye. So it also may present with the normal or decreased visual acuity, conjunctiva or ciliary injection, visible foreign body. And for the picture above it, for the picture below, it is a rust ring. Rust ring may occur if the metallic foreign body has been embedded for hours to days. And then corneal edema, anterior chamber flare, epithelial defect that stain with the fluorescence also can occur. So next. And then for the management of the corneal foreign body, as the first attempt is the saline irrigation. So if fail, can use the sterile cotton tip swab. And then if the above ways is still fail, we can remove the foreign body under the magnification using the local anesthesia and sterile hypodynamic needle and treat the remaining epithelial defect as abrasion. So we can apply the antibiotic ointment and 24 hours of the follow-up is mandatory. So that's from me.
Beautiful. Okay. So just to complete, a foreign body can be different types, just like you mentioned, and then of course we need to take it out, and we need to see what is the remnant after this foreign body. Is there any infection happened to this cornea? Any inflammation going on? So you can say that there is a foreign body induced corneal ulcer sometimes. So we need to cover with antibiotics, and we need to give proper lubrication for this cornea to help the healing. Sometimes when you move the foreign body, there is a remnant rust, so you need to have consideration in the next visit that you remove the remaining rust. which cannot be removed from the first setting. It all depends on the presentation of this patient. And the proper thing in management, if the patient is, let's say, and this is why we ask about the history of the job and the occupation of the patient. You have to prevent this thing from happening again. So you have to explain to the patient to use protective glasses and how to protect the eyes, not to have this foreign body again. Can. Let's say he's working as a welder or something like that. It depends on the patient, but short and excellent presentation. Okay, the next topic. Right.
Okay, Assalamualaikum and good morning. So, next I present about the traumatic hyphema. Next. So, traumatic hyphema is the blood in anterior chamber. Anterior chamber is anatomically defined as the space bordered by the cornea, iris, angle, and also the lens. Usually, clear aqueous humor normally fit in the space, as you can see the picture below. So, the source of bleeding is typically the iris root or ciliary blood body phase, and it most commonly due to trauma. For the children, they are typically injured through ball-related sports such as baseball, and for the adolescent and adult, it's more likely to be injured via a high-energy blow to the eye. So, bleeding results from the tear in the vessels of the ciliary body or iris can be graded based on degree of anterior chamber hemorrhage. So, for the first one, microhyphema, it is when there is no layering of blood, but blood cells are seen within the anterior chamber. For the grade 1, layered blood occupying less than one third of the anterior chamber. For the grade 2, layered blood filling one third to one half of the anterior chamber. Grade 3, layered blood filling one half to less than the total of the anterior chamber. And grade 4, total clot blood, often referred to as blood ball or egg ball hyphema. Next. So this is the pathophysiology of the hyphema. When the blood passes to the eyeball, it will instantaneous increase in intraocular pressure, equatorial stretching of the globe, and posterior pressure being transferred to the iris and also its root. Uh, and transient rise in pressure results in shear force acting on the angle structures and can mechanically disrupt the angle. This will result in hyphema, which due to the tear in the vessels of the ciliary body or iris. Uh, I think that's all. Next, Hafiz will present.
Okay, also patient with traumatic hyphema will present with clinical findings such as visible blood in front of the eyes, as we can see in the picture. And if the blood is small or little, it might not be visible. And the patient also might complain of blurry, clouded, blocked vision or total vision loss. And the patient also might complain with pain, photophobia, and also elevated intraocular pressure, which is due to the blockage of the trabecular outflow by the red blood cell or any inflammatory debris. Okay, next slide. So how do we diagnose traumatic hyphema is by using history taking. If there is any history of trauma or other condition that could lead to bleeding in the eye, and also examination by using the pen torch if the blood is visible, and also we can use slit lamp examination to confirm the diagnosis. Okay, next slide. So for management, I divided into three, which is general, medical, and surgical. For general, screening for sickle cell disease is important as people with sickle cell disease is more likely to develop secondary glaucoma because of increased blockade of the trabecular outflow by the sickle cell, and thus have a higher likelihood of visual loss from hyphema regardless of its severity. And next is most hyphema are self-limited and usually resolve within 1 week. Bed rest, head of the rest elevation more than 30 degrees, and eye shield may be sufficient. And medications such as anticoagulant, antiplatelet, and analgesic such as NSAIDs should be discontinued for prevention of continued or secondary hemorrhage, because secondary hemorrhage have worse prognosis. So for medical, we can use topical corticosteroid, cycloplegic, topical beta blocker, and also antifibrinolytics. For surgical management is indicated in cases refractory to medical treatment, persistent high-grade hyphema, corneal blood staining, persistently elevated intraocular pressure, and uncontrolled glaucoma. Surgical options include anterior chamber washout with irrigation and aspiration, trabeculectomy, peripheral iridectomy, and anterior chamber paracentesis. However, all these surgical options are associated with risk of secondary hemorrhage and damage to the cornea, lens, and iris, and are considered only in cases not responsive to the medical treatment. Alright, that's all for traumatic hyphema.
Excellent. Okay. So, just if you allow me, Oya, and then you can say the comment just after. Hyphema can be of two types, either spontaneous or traumatic. And this is necessary to know and elicit from the history of the patient. Second is, what is the significance of this hyphema? Of course, our ultimate goal is to protect this eye. Presence of blood in the anterior chamber can affect, and according to the explanation of the pathophysiology just now, can lead to the increase of the intraocular pressure. And if it's traumatic, one of the important examination will be examining your angle. Something associated with traumatic hyphema will be your angle recession. And then angle recession can be associated with a long-term glaucoma to exist in this eye. So a long-term follow-up of such patient can be considered. So an increase in intraocular pressure and glaucoma to happen can lead to permanent optic nerve neuropathy and permanent loss of vision. So this is not an how to say a cold matter. No, we need to consider this case. How do we signify the importance, or let's say how bad this hyphema is the complications of this hyphema. So as you guys just presented, some of the complications will be associated with the increased intraocular pressure. Some of them will be associated with corneal blood staining. Some of them will be associated with a chance of recurrent bleeding, and all of which need to be considered for the treating doctor whether to go surgically and wash out this AC or not, to clear this hyphema or not. So we do get afraid sometimes of corneal blood staining, which can sometimes be permanent, and it can affect the visual acuity of this patient. And then the management will be to admit such patients, depending on the level of the hyphema, bed rest, prop up position to allow this bleeding to have a level, and you can see what is the level of your hyphema, and then to judge whether you need to go in and for surgery or not, of course, with a close follow-up of how is your IOP. And then we need to cover medically with steroids. We need to cover with we need to examine all the other areas, which means you need to examine your iris. Is there any iridodialysis? Is there any sphincter tear? Is there, I mean, you have to examine the whole thing. Is there any associated zonulodialysis, echodenesis, which is the instability of your lens? Any related to trauma signs that you need to find in your examination. But excellent presentation. Okay. Owi, just now you were about to say something, Owi?
Yeah, like what Ali said, like what you said, the three most common complication is optic neuropathy, glaucoma, and also the corneal blood staining. So I think these three is the most important take home message. And also for traumatic hyphema, it's not only for blunt trauma, like what you say is can have a spontaneous one, can be due to underlying disease like sickle, underlying disease also, and also it can be due to penetrating injury and can cause hyphema as well. And in all trauma case, you need to see the association, not only the hyphema, like your iridodialysis, your focal, your lens displacement, lens dislocated, and your retina, any commercial retina, any retina detachment, retina break. That's all.
Right, excellent. The next presentation.
Okay, sit with the campaign, right? So the campaign of sensitivity vary from given hesitation to complete and sudden loss of vision. So the rigidity of the campaign is limited, but
to assault methods of the burns, but that occur at work, haunted at home. Also for the alkali burns, twice as common as acid burns, and alkali is quite used by industry. So for the severity of the chemical injury, it's related to properties of the chemical, area of the effect of the surface, and the duration of the exposure-related effects, such as the this chemical injury are confidentiality and immediate treatment. Next, next is the type of next is the type of injury. First one is alkali, and the second one is acid. So you can see the alkali agents such as ammonia, potassium oxide, and lime. So these alkali agents they are lipophilic, and therefore they will penetrate tissues more rapidly than acids. They will simplify the fatty acids of the cell membranes, penetrate the corneal stroma, and destroy the protein cross substance and collagen bundles. And the damaged tissue will then secrete photolytic enzyme which lead to the damage. So in contrast to the acids are generally less harmful than the substance because they cause damage by denaturing and precipitating proteins in the tissues they contact, and the coagulated protein will act as a barrier to prevent further penetration. As opposed to the alkali, the damaged tissue will secrete the coagulated enzyme, which then for the damage. So the one exception in the acid is hydrochloric acid, which the chloride ion rapidly penetrate the thickness of the cornea and cause significant anterior segment destruction. Next is the clinical features of the acute the conjunctival will should edema, congestion, widespread necrosis, corpuscular discharge. For cornea, they will be swelling and they will be inflamed iris. For the acid burns, the conjunctival will show cyst, pain, and simplified consequence in addition
Is hello? Hi, are we here? I'm not sure is my line problem or is it really breaking?
For me, also, it is breaking.
Yeah.
But yeah, let's read the slides with the presenter and try our best to follow up. So you can just correct your line, whoever is presenting. Your voice is breaking. Okay.
for the acid, clinical features of the conjunctival will show immediate necrosis, sloughing, and simplification. So simplification is the addition between the vulva and what is shown in the picture, and then the cornea will show the pupils and the so next is the toxicity. So any exposure to the acidic or alkali will cause the chemical eye injury, and then the chemical eye injury will cause necrosis of the conjunctival and corneum with disruption and occlusion of the limbal vasculature. So for the pigmentation, cause the breakdown and precipitation of glycose and plankton that will lead to stromal corneal opacification, and penetration to the anterior chamber will cause the iris and lens damage. Then will lead to damage to the ciliary epithelium. We reduce ascorbic secretion that will cause impaired collagen production and corneal. Next.
Okay, Assalamualaikum and good morning. I will proceed with management of chemical injuries of the eyes. Okay, most often the patient that come with the chemical injuries of the eyes will give a history of liquid or gas being splashed or sprayed into the eyes, or the history of particles falling into the eyes. And patients' complaints are frequently related to the severity of the exposure, regardless of the specific mechanism of injury. So common complaints are pain, which is often extreme, foreign body sensation, blurred vision, excessive tearing, photophobia, and red eyes. And on examination, findings may include cornea haziness, loss of eyelashes, eyebrow, burn mark, cornea perforation, limbal ischemia, conjunctival hyperemia and ecchymosis, uveitis, reduced vision, increased intraocular pressure, and also decreased visual acuity. Okay, on the right side is the grading frequently used for acute chemical injuries to plan for subsequent treatment and to determine the prognosis. And the grading is usually performed on the basis of corneal clarity and also the severity of limbal ischemia. And it is called as Roper Hall system classification. So it consists of grade 1 until grade 4. And for grade 4 and
Next
sometimes...
slide. It's all right. We can refer to the table for the grading. The next slide.
Okay, next. Okay, the goals of management include removing offending agent via irrigation, promoting ocular surface healing, eliminating inflammation, preventing infection, and also controlling intraocular pressure and controlling the pain. Okay, next slide. Okay, when the patient give a history of liquid or gas being splashed or sprayed into the eyes, so we should ask them regarding the specific nature of the chemical and also the mechanism of injury. For example, if it is a simple splash or high velocity blast, and also we can ask them if they have used any sort of eye protection during the chemical splash, and a complete eye examination should be done after the affected eye is irrigated copiously and after the pH of the ocular surface have neutralized. Topical anesthetic drops may be used prior to irrigation to help patient in comfort and also to help patient in cooperation. So for irrigation, we irrigate the eyes immediately with 6 pints of normal saline, which is about 2 liter to 3 liter. And after 10 to 15 minutes, we check the pH of the ocular surface. If it is still not neutralized, then we should continue the irrigation until the ocular surface neutralized to pH about 7 to 7.2. And then we should monitor the pH at 15 to 20-minute intervals after stabilization and ensure that no further particles are present to continue changing the pH. And then once the irrigation finished, we can do a complete through eye examination. Okay, next. Okay, and then once the chemical has been completely removed, we may start patient with the medical treatment, which include first, topical antibiotic drops, which are used for prophylaxis of bacterial infection. Second is topical steroid, which reduce inflammation and neutrophil infiltration and can also address the issue of anterior uveitis. Third is topical cycloplegia, which can manage the ciliary spasm and reduce the pain from the burn and provide comfort to the patient. And then fourth is ascorbic acid, which plays important role in collagen remodeling and lead to improvement in cornea healing. Fifth is citric acid, which is a powerful inhibitor of neutrophil activity and reduce the intensity of the inflammatory response. Next is tetracycline, which can decrease the risk of cornea melting and ulceration. And then last but not least, intraocular pressure should be monitored, and if necessary, we may give treatment of oral acetazolamide to avoid adding further pressure to the ocular surface. Okay, next. Okay, this is the surgical management of chemical injuries. You guys may read it later. Okay, next. Yeah, these are some complications of chemical injuries of the eye, which include conjunctiva inflammation, cornea abrasion, cornea haze and edema, acute rise in intraocular pressure, cornea melting and perforation, ulceration, bulbar conjunctiva scarring, globe atrophy, secondary cataract and glaucoma, secondary severe dry eye, and lid scarring, trichiasis, and entropion. Okay, that's all from me. Thank you.
Excellent. Okay, excellent. So chemical injury is one of the ocular emergencies to us. Just a point to shine the light on, always examine your patient systematically and ocular. So you have to also see what's wrong, what's going on systematically. Is there any extraocular damage that happened according to this chemical injury? That's one. Second is to care about how is the prognosis of this eye. Of course, when you examine, you want to examine the points that will lead you to decide how is the prognosis, which is your corneal haziness and your limbal ischemia and how bad this chemical injury happened. Chemical injury tend to be so aggressive sometimes, and then very poor prognosis, even if the corneal haziness happened and the limbal stem failure already existed, there is a very poor chance of rescuing this eye even after doing the definitive management, which is your penetrating keratoplasty. The prognosis in such surgeries due to chemical injury is not very good. Okay, excellent. The next presentation. Uwe, if you have any comment, you can jump in.
Yeah,
Time?
for chemical injury, the management part, I think, can you put back to the history part? It's okay. Usually we will say it's a ocular emergency. You don't take all the history first. You just take a brief. You know what's the agent that causes the chemical injury, and you straight away irrigate the eye. Do not wait until you take the full history. Okay. So yeah, the rest is quite okay. Just don't wait until you take the full history. You straight away irrigate the eye first. While irrigating, you can take the history. Okay. Next.
Okay. Next presenter.
Good afternoon to doctors. So my name is Wei Hua. This slide prepared by Hazira and me. So I will continue the presentation with the conjunctivitis. The definition of conjunctivitis is any form of the conjunctiva inflammation. So there are few classification. The first is based on onset. It can be acute, subacute, or chronic. Acute means that it persisted less than 4 weeks, and chronic means that it is persisted beyond the 4 weeks. And based on the type of the exudate, this is important because it is linked to the etiology. So for the serous is watery discharge, and it could be viral, allergy, or toxic in origin. The catarrh, which is more viscid but still clear, it is allergy in origin. Purulent is bacteria, and mucopurulent is linked to the bacteria and chlamydia discharge. Membranous and pseudomembranous is the severe form of the bacterial conjunctivitis. It is due to the coagulation of the fibrin on the conjunctiva surface. So based on the conjunctiva response, this one you guys can refer to it later on. And based on the etiology, which is the main part of the presentation, it could be divided into infectious conjunctivitis and non-infectious conjunctivitis. For the bacterial conjunctivitis, the most common causative agent is the Staphylococcus aureus. And other example could be the Streptococcus pyogenes, Streptococcus pneumonia, the Neisseria gonorrhea, and Neisseria meningitis more commonly happen in the children. For the viral, the more commonly one is the adenoviruses and also the herpes simplex virus. So other example are the chlamydia, the fungal, and also the parasitic. However, the bacteria and the viral are more common than other causative agent. So for the non-infectious conjunctivitis, we have allergy, irritants, endogenous or autoimmune dry eye, toxic, such as the chemical injury that have been mentioned just now can lead to the conjunctivitis, the factitious or self-inflicted, and also the idiopathic. Next slide, please. So this slide is about the acute bacterial conjunctivitis. So for the pathophysiology, our conjunctiva has two mechanisms. For the primary mechanism, it is composed of the epithelial layer of the conjunctiva. For the secondary defense, it is formed by the hematologic immune mechanism, by the conjunctiva vasculature, the tear films, immunoglobulin, the lysozyme, and also the lacrimation
I'm
and
sorry, but
ligation.
just for time saving, your explanation is so good in the table, so maybe we can refer to these tables and read about all the things you wrote. Just for time sake, do you want to show the clinical signs? Do you have photos of what to see in this conjunctivitis?
Yes.
Like,
Moving
just
on to
show
the
the
next slide.
pictures and then, yeah. And then the principles of management is depending on the infective agent. Excellent. Okay.
Yes. So referring to the table, we can see that the table picture number A show that there is an eyelid edema and also the erythema, and picture number B show that there is a conjunctiva injection at the bulbar conjunctiva and also at the palpebral conjunctiva, and the picture C similarly showing the conjunctiva hyperemia, and the D showing the purulent discharge. And referring to the figure 3 at the bottom left side, we can see that there is some conjunctiva papillae formation. This is due to the hyperplasia of the capillaries. So for the principle of management, can we back to the previous slide?
No need. It's all right.
Oh.
It's all right.
Oh, okay, sure.
Just two more things. Two more things. You need to look for something called membranes that is associated with conjunctivitis, and this can be against the treatment, not allowing this agent to interfere and take its action. And sometimes it's associated with pseudomembranes, which we can remove and allow the medication to take its action. So this is why sometimes close follow-up of conjunctivitis is needed, and according to the type, just like you mentioned. And one more, two more, is you have to know, is there any associated systemic conditions? So we have the VKC, the vernal keratoconjunctivitis, and the AKC. So as the term keratoconjunctivitis, always examine your cornea. To whatever is conjunctivitis is existing, you have to know what's happening in your cornea to save this eye, not to develop complications later on. All right, next slide.
Okay. Next slide, please. So moving on to the
I mean, it's already
conjunctivitis.
12:20, and okay. I think you guys can refer to the explanation because it's explained so well. The next one will be move to the next slide. Also, it's okay.
Okay.
It's already 12:20, and we are only at topic number 7. You guys have this session until 12:30. We can add some more time if you are. Are you flexible with your schedule? We can add a little bit more of time to cover all the topics. I would like the presenters to go as fast as they can, just to present the most important in each topic. The writing and all of this, you guys can skip and you can go read among yourselves. We are here to present the most important things, just to discuss. Okay. Yeah, I'll leave it to you as a presenter. You can finish the presentation, but no need to read everything, just the pictures, and move on for the next presentation.
Okay, sure, doctor. So for the viral conjunctivitis, compared to the bacteria, we have the conjunctiva follicle. Just now is the conjunctiva papillae. So for this, due to the formation of the follicle, the patient can complain of the foreign body sensation, or there is some grittiness of the eyes. So it is also called as the grain of rice. Okay, next slide. So for the allergic conjunctivitis, the pathophysiology is involvement of the type 1 hypersensitivity reaction of the exposure to the allergen. So the patient can have the, normally is involved the bilateral eyes. The patient can have the chemosis, which is the conjunctiva edema, the conjunctiva injection, and also some watery or the watery stingy discharge. So for the principle of management, we advise the patient to have the basic eye care, which is do not rub the eyes, apply some cool compression and artificial tear to dilute the allergens repetitively during the day, and reduce the usage of the contact lens at the time beings. And also the allergen avoidance, such as limit the outdoor exposure, replace the old pillows, and also wash the beddings. We can also give the topical antihistamine, the vasoconstrictor combination eye drop to the patient, which is for the short-term relief. So for the acute relief or prophylactic relief, we can also give the systemic antihistamine. The topical steroid is given. However, it requires the ophthalmologist supervision. So that's all from me. Thank you.
Nice. Also, you need to assess systematically, is there any associated allergic rhinitis, and you refer to the ENT? Is there any bronchial asthma, and you refer to the specialist related to these things? So it's a common issue in ophthalmology, the conjunctivitis, but it seems to be easy sometimes if it is responding to treatment, yet it can get ugly and complicated in some cases. And depending on what are we dealing with, what is the disease we are dealing with. But excellent. And nowadays, we have this pandemic and the COVID-19. COVID-19 can present sometimes with conjunctivitis. Okay. So you need to, be aware of all this stuff. Okay, the next presentation, and we'll try to minimize the time to 2 minutes each. I know that you can imagine how fast we can go, but we are trying to cover as much as we can. Okay, next presentation.
Okay, so for the next presentation is preseptal and orbital cellulitis. So one key point that you need to remember from this is that the differences, okay, because it's easier to remember. So for preseptal cellulitis, you just remember it's preseptal. So it's before, or it's anterior to the orbital septum. So the margin is the orbital septum. So if orbital cellulitis is posterior to the orbital septum. So the pathophysiology, I think you can read it. So the general idea is that the pathogens reach either the dermis or subcutaneous tissue for preseptal cellulitis, and for orbital cellulitis, the pathogen reaching the orbital tissue. Okay, so next, please. So this is a clinical finding. So what you need to remember is that one of the presentation of preseptal is unilateral tenderness and red lip of the affected eye. And this is going to be periorbital edema, and patient is often paraxial. However, for orbital cellulitis, because as you remember, the orbit is affected, so as well as the as well as the structure behind in the orbit, such as the fats and the muscle as well. So there's going to be a rapid onset of pain worsen by eye movement, as well as rapid onset of malaise, fever, and there's going to be a swelling of the eyes and painful ophthalmia. And for next, please, for treatment, I'll pass to my friend.
Okay, so for
So
investigations,
before you go and pass to your friend, it is sometimes dealt as an ocular emergency sometimes, because this is not an easy issue as of the complications that is happening. Now, preseptal cellulitis with close follow-up, you can judge, is it going on to be orbital cellulitis or not? And sometimes we admit patients and we have to give IV antibiotics to stop proceeding and continuing of this infection to go inside. So we're trying our best to protect this eye. Yes, catastrophic complications can happen because this area is related to very sensitive and very um, important structures. So it can lead to abscess formation, periosteal abscess, intraorbital abscess, transmission of this infection behind, and then it will lead to cavernous sinus thrombosis sometimes. It can lead to meningitis. It can lead to intracranial abscess. And this is where the next presenter now will present about the investigations. You will need to do imaging of the brain and orbit.
Before that, I think you need to differentiate the preceptor and orbital cellulitis. Usually, the orbital cellulitis will have a pain on eye movement. The conjunctiva is very chemotic compared to preceptor, and the eye may be very proptose compared to preceptor. Preceptor, there's no eye proptosis, and the extraocular muscular movement of the orbital cellulitis will be affected as well. The eye will be not moving fully. And also they can have a complication like optic neuropathy compared to preceptor. Okay. Okay, next.
okay, so for the investigations, for preceptor cellulitis, you could do MRI or CT scan. However, this is only in the case of orbital cellulitis is suspected. So you suspect that the preceptor cellulitis have progressed into becoming an orbital cellulitis, then you can do the MRI or CT. For orbital cellulitis, in the case of there is a history of trauma, it might be worth that you actually check the tetanus immunization of the patient. You can also do white blood cell count, blood culture, and also culture of the nasal discharge if there is any nasal discharge. Next again, repeat, which is high resolution CT of the orbit, sinuses, and brain, so you can see what aspect of the eye has been inflamed. And last, if there is a meningeal or cerebral signs developing, you can also do lumbar puncture. So for next is the principles of management.
Okay.
The principles
So
of,
basically, it's just searching for where is the focus of infection. Sometimes it's dental, sometimes it's the sinuses. So, you have to search where is this infection coming from, right? Okay. And then the principles of management will be the admission and all that. Beautiful. And then the close follow-up and how is the resolving of your orbital cellulitis or preseptal cellulitis. Anything else more than this slide?
nothing, doctor. Next is different.
All right. Excellent.
Okay,
So
thank you.
yeah, it is an emergency and it is something necessary to cover about in and out. And you have to know what is the difference between preseptal cellulitis or orbital cellulitis. Orbital cellulitis need to be referred immediately to ophthalmology and admission is required. The next presentations, please be fixed to 2 minutes each and we can start.
Okay, I'll present about the blood fractures, orbital blood fractures. Okay, next. Okay, it's occur when the sudden increase in the orbital pressure due to the high impact and impact from anything larger with diameter of orbital opening, which is more than 5 cm, which is just as fist or tennis ball, and it can lead to dislocation of the eyeball. So the dislocation depend on the direction of the impact, which is four type, which is orbital floor fracture, roof fracture, lateral wall fracture, and the medial wall fracture. Okay, next. Okay, for the clinical findings, there is periocular sign, which is the variable ecchymosis, periorbital edema, and subcutaneous emphysema. And other more is the enophthalmos, which eye become recesses into the orbit, and diplopia, which is the hemorrhage and edema in the orbit, which may cause septa connecting the inferior rectus and the inferior orbit muscle to the preorbital to become taut and this restricting movement of the globe. And lastly is the infraorbital nerve paresthesia, which is involving lower lid, cheeks, side nose, upper lip, and upper teeth, and gum, very common. Okay, next, move to the investigation.
So for the investigation, we use the CT scan that can reveal the herniation of orbital fat or the inferior rectus muscle into the maxillary sinus. And CT scan can also detect occult tears and retain foreign bodies. And the second one, we can use plain radiograph. It can help suspect an orbital floor fracture in the presence of the following, which are subcutaneous emphysema, soft tissue teardrop along the roof of maxillary sinus, and air fluid level in the maxillary sinus. And next, for the treatments, the goal of treatment is to restore aesthetic and physiological function. First, we would like to ask patient to refrain from coughing or blowing nose as it can worsen the orbital emphysema. And then antibiotic may be indicated, especially if patient had history of chronic sinusitis, diabetes, or immunocompromised. Then surgery can be done if fracture is more than 50% of orbital floor, diplopia not improving, or enophthalmos is more than 2 millimeter. But it may delay the surgery if the diplopia improves. Okay, that's all.
One thing to add on for surgery, the most fearful one complication is the ocular cardiac reflex and also your white eye trapdoor, which can cause a necrosis. So these two is the surgery must be immediate. Okay, and another one for the term blowout fracture is only for the inferior wall fracture Okay, that's all from me.
So what we is saying is we need to rule out any extraocular muscle entrapment in this fractures. And yes, sometimes we do need to go immediately for surgery depending on the presentation. Whether is it developing oculocardiac reflex or white eye trapdoor presentation. Okay, next presentation.
Y'all can go to read out white eye trapdoor, okay? Right.
Right, next, I'll be presenting on scleritis, whereas I will be presenting on scleritis. So basically, this is a quick differentiation between scleritis and also scleritis clinically. The slide, sorry. Yeah, as you can see, there are 3 layers of vessels. Sorry, previous slide. There are 3 layers of vessels. Superficial, intermediate, and also deep layer of vessels inside the sclera. So basically, scleritis, the maximum congestion will be at the layer of superficial, whereas for scleritis, the maximal congestion of blood will happen at the deep vascular plexus. Right, next. So just a very brief similarities and differences between episcleritis types. There are 2 types of episcleritis, simple and nodular. Episcleritis is actually idiopathic and also benign. Pathophysiology is unknown. Under microscope, you can see a non-granulomatous inflammation. So it happens more in female in middle age. It is usually self-limiting and happens a few days to 3 weeks. So simple episcleritis and also nodular episcleritis, both of them are similar in terms of you have eye redness. But then nodular episcleritis is normally more severe, and also you can find a nodule at the sclera in between in the interpalpebral fissure, and it also has a worsening discomfort in nodular episcleritis. So simple episcleritis has a shorter course of duration. It peaks within 1 day and then it gradually fades. Whereas nodular episcleritis, it has a less acute onset and also more prolonged course. So the signs, normally visual acuity is preserved, and whereas after several episodes of inflammation of vessels in nodular episcleritis, the vessels can become permanently dilated. Right, next slide. Right, principle of treatment to reduce discomfort and also inflammation in the eyes. So treatment, if it is mild, then we can just use cold compress or just use refrigerated artificial tears, and we can also give topical steroids 4 times a day for 1 to 2 weeks in more severe cases. NSAIDs can also be given is if steroids are not tolerable, but then it is less effective compared to steroid. Other than that, we need to treat the underlying cause because it could be associated with ocular diseases such as dry eyes, contact lens wear, and also systemic collagen vascular disorders in episcleritis. Right, that's all. Next, scleritis.
Hello, Assalamualaikum and good afternoon. So we present about the scleritis. So scleritis is an uncommon condition characterized by edema and cellular infiltration of the entire thickness of the sclera. So sclera ni is much less common compared to epiglottitis. Okay, classification of scleritis divided into two, which is immune-mediated and infectious. So next. So immune-mediated, it will divide it into anterior and posterior. So under anterior pula, it will be divided into two, non-necrotizing and necrotizing. And then under non-necrotizing and then akan divided into two, which is diffuse and nodule. Then necrotizing akan divided into two, inflammation and non-inflammation. So kalau for the symptom for the each type ni will be different, which is for example for the necrotizing diffuse will be there is ocular redness for a few days, later will be developed to pain, and then patient will patient have patient will wake early because of discomfort too, and then patient also claim that they eat Panadol but cannot resolve the pain. And then for the nodule, obviously patient will have a nodule appearance on the sclera, and also the onset of pain is sudden in onset. Okay, for the inflammation necrotizing, necrotizing inflammation, the gradual onset of pain become severe and persistent and ready to temper. It also interfere with sleep, poor effect with the energy.
It's okay. Next.
Okay. Okay.
Next.
Next. Go to the slide that have investigation, complication, and
Yes.
treatment.
Yeah. This one.
So for the investigation, so this is investigation that we can done, which is laboratory, radiological imaging, angiography, ultrasonography, biopsy. And then the complication for the anterior immune-mediated scleritis, it can be acute infiltrative trauma keratitis, sclerosing keratitis, glaucoma, hip tony, and perforation. And then treatment for the immune-mediated, we can give topical steroid, systemic NSAID, preocular steroid injection, and immunosuppression and or biological blockers. While for the infectious, we need to treat the underlying causes. Okay, that's all from me. Thank you.
Okay, all right. So for episcleritis, because it's idiopathic, benign, usually we treat the patient and let go. Only if it's present the second time, we need to investigate if there is any systemic condition. Scleritis is something else. We need to investigate from the first time. We need to rule out any associated systemic diseases and all that. So there will be some modification, guys. We can skip uveitis. I would like you guys to read all about it. Let's present about acute angle closure and corneal ulcer. And for lid laceration and cataract surgery, also we can skip. And this is not a skip because it's not important. No, it's all important, but because of time, and I know you guys are more aware of the importance of all the topics, but for time's sake, let's present about acute angle closure and corneal ulcer, and we can wrap up. And we did an excellent job. Thank you all very much. For lid laceration in general, you need to rule out any ocular damage also. Yes, the lid is injured, but you need to rule out, is the eye involved or not, the globe itself. For the cataract surgeries, you guys will cover while you attend in the OT and you see the surgeries. You have to cover all the types and you come prepared, reading about all the types, whether it's intracapsular or extracapsular cataract extraction or the phacoemulsification and all that. Okay, so let's start with angle closure. 2 minutes, 3 minutes, and then corneal ulcer, 2 minutes, 3 minutes, and that's it.
Okay, good
Okay.
afternoon,
You
everyone.
agree? You agree, Oi? No problem?
Yes, no problem.
Okay.
Only the uveitis you all need to read out because the uveitis is also very important. As a lot of association, like especially the systemic association. Okay, so you all need to go and read out the uveitis. Right, all right.
Okay, so I will continue with the acute angle closure. Next slide. Okay, so for the pathophysiology of the acute angle closure, so as you can see in the picture yang the lens yellowish lens, so the normal physiology, the cerebral body will produce the aqueous humor, and then this aqueous humor will be moved into the anterior chamber and then drains into the trabecular meshwork. So in acute angle closure, as people aging, so the zonula becomes weakest. So this zonula hold the lens to the ciliary body. So when this zonula becomes weakened, and then it will cause the lens to become more globular, and then this lens will move forward, and then anything that in front of the lens, which is pupil, will touch the iris. So this will block the pathway of the aqueous humor from the ciliary body to the anterior segment. And then when the aqueous humor accumulated behind the iris, it will push the iris forward, and eventually it will close the pathway of the aqueous humor to the trabecular meshwork. So the trabecular meshwork cannot drain the aqueous humor, and then the aqueous humor will accumulate in front of the in the anterior segment, in the anterior chamber, and then it will give rise to the intraocular pressure, which later will give rise to the symptoms of the acute angle closure. Okay, next slide. Okay, so this is what I explained just now. Okay, next. Okay, so as for the classification of the acute angle closure can be divided into primary or secondary. So for primary, it occurs in the anatomically predisposed eye. And for secondary, it is due to the another ocular or systemic factor. For example, like swollen of the eye that because of the trauma. But for the classification, I will focus more on the primary classification. So for primary classification, it can be classified into the primary angle closure suspect, primary angle closure, and also primary angle closure glaucoma. So for the first classification, primary angle closure suspect, there is presence of appositional contact between the peripheral iris and posterior trabecular meshwork, meaning that, as you can see in the picture labeled B, so we can see the lens comes into the contact with the iris. So this what occur in the primary angle closure suspect. For the primary angle closure, the presence of occludable drainage angle with the evidence of peripheral anterior synechiae. So meaning that the peripheral anterior synechiae is a condition where the iris adheres to the angle. As you can see in the picture labeled C, the iris comes into the contact with the cornea, which prevent the drainage of the aqueous humor in the anterior chamber to the trabecular meshwork. So this will give rise to the intraocular pressure. But for primary angle closure, it's without the glaucomatous optic nerve damage. But when there is glaucomatous optic nerve damage, it becomes primary angle closure glaucoma. So next.
Okay, so I'll present about the diagnosis of glaucoma. So diagnosis of glaucoma is based on history, including the presence of risk factors and also the eye examination. So during the history taking, patients may be asymptomatic or complain of reduced vision, ocular pain, redness, and halos. Patient also may complain of headache, nausea, and vomiting, which indicate the increase of intraocular pressure. For the risk factor, in the ocular history, patient may have history of ocular surgery, trauma, and use of topical steroid. For the refractive status, myopia may contribute to the primary open angle closure, angle glaucoma, while the hyperopia will contribute to the angle closure. For the system history, patient may have system history of diabetes mellitus, hypertension, migraine, Raynaud phenomenon, and use of systemic steroid, and also the obstructive sleep apnea syndrome. Patient may also have family history of glaucoma, and also other risk factors that contribute to the angle closure glaucoma is older age and also women. So during the examination, for the visual acuity is usually normal, but may be reduced in acute or advanced glaucoma. For the pupil, it may be mid-dilated pupils in the acute angle closure, presence of posterior synechiae, and they may have a relative afferent pupillary defect in asymmetrical cases. For the anterior chamber and lens, the depth of anterior chamber is shallow in patient with primary acute closure. Peripheral anterior synechiae iris wording and atrophy, presence of anterior subcapsular opacity, and also cataract. For the intraocular pressure measurement, we may use the Goldman applanation tonometry, which is the gold standard. And then for the assessment of the angle, we use the slit lamp examination and gonioscopy. For the assessment of the optic disc and retinal nerve fiber layer, we use the slit lamp examination biomicroscopy using high power condensing lens, or stereoscopic optic disc photography, or red pre-illumination, or also direct ophthalmoscopy, in which the optic disc we can see the laminar dot sign, the beam port sign, and also the nasalizations of the artery. Okay, next slide, please. So this is the diagnosis of acute angle closure. You can read more on this because this is I already explained in the previous slide. Okay, next. So for the investigation, we can do the automated visual field analysis using the standard automated parametry, in which we can see the visual field defect. We can also do the optic nerve head and retinal imaging to detect glaucomatous structural damage. And we can also do the central measure the central corneal thickness because it is important in patients management. And then we can measure the anterior segment optical by the optical coherence tomography. This is to detect more angle closure compared with gonioscopy. Okay, next. So for the principle of management, it is aimed to reduce the intraocular pressure urgently and relieve the acute symptom. We have the medical, laser, and also surgery. For the medical, we have the topical prostaglandin analog such as latanoprost. We have the topical beta blocker, topical astazolamide, and also systemic astazolamide, which we administer intravenously. We have the laser peripheral iridotomy, and surgery such as trabeculectomy, glaucoma drainage device, and minimally invasive glaucoma surgery. You can refer to the diagram on the right side. Okay, so that's all from me. Thank you.
So basically, if there is a pupillary block, you need to relieve this pupil block. This is why we do the laser peripheral iridotomy as fast as we can. So we create another opening for this aqueous to come to the anterior chamber. And this will depend also on how hazy your cornea is. In the signs just now, there was hazy cornea because of very high IOP. As long as you bring this IOP down, sometimes we give IV systemic acetazolamide like IV Diamox. Bring this IOP down, clear this cornea, go in for laser peripheral iridotomy. And then you proceed on for the judgment of how is the long-term management of this eye. Ultimately, we need to protect this eye not to develop glaucoma and optic neuropathy, which eventually can be permanent. So this is the whole idea. Excellent presentation. Okay, the next will be the last presentation, corneal ulcer.
Okay, so I will be presenting about the corneal ulcer. So corneal ulcer is basically a manifestation of infectious keratitis due to organism that can cause tissue death or necrosis and pus formation in the corneal tissue. Next. It can occur as in primary event or maybe secondary to an event that has compromised the eye, like in contact lens wear, any trauma, any immunocompromised patient, or any long-term steroid use. And it can be caused by three types: the bacterial, fungal, or viral. So bacterial keratitis can be most commonly caused by the Pseudomonas and Staphylococcus aureus, while the fungal can be because of Aspergillus fusarium or Candida albicans or the yeast, and viral is usually by the herpes simplex virus. Next. So the clinical findings, usually the symptom, patient presented with pain and discharge. So discharge in bacteria is mucopurulent, while in fungal is watery discharge. And patient can have photophobia, blepharospasm, or eye twitching, and reduced visual acuity. And the signs may be presented with red eye with loss of vision, conjunctival and circumcorneal congestion, hazy cornea, necrotic slough at the base of ulcer. Hypopion is the pus cell in the anterior chamber of the eye. Vascularization, encapsulated of corneal abscess, and prolapse of uveal tissue. Next. So the pathophysiology is divided into the 4 stages. The first stage is progressive infiltration, where the lymphocytes will infiltrate into the epithelium from the peripheral circulation and underlying stroma that causes necrosis of the tissue. So in stage 2, or the stage of active ulceration, it results from the necrosis and sloughing of the epithelium, Bowman's membrane, and the involved stroma. and hyperemia of the circumcorneal vessel, resulting in accumulation of purulent exudates of the cornea, and ulcer may progress to hypopyon and descematocele formation. In stage 3, where the stage of regression, it is induced by natural host defense mechanism, where the leukocytes will phagocytose the necrotic debris that results in initial enlargement of the ulcer. While then, neovascularization will occur to increase the immune response and ulcer begins to heal. In the stage 4, the cicatrization, where the healing continues by progressive epithelialization that forms a new covering, and scars and opacity formation will occur. Next.
Okay, I will continue about the investigation and management. The investigation for corneal ulcer is the diagnosis is made based on the clinical findings of corneal epithelium defect that stains with the fluorescent and is accompanied by the surrounding infiltration with or without a pleuron or necrotic lodge at the base. So therefore, Slidell test is done, and other than this test, microbiological investigation also will be done to identify the causative organism by doing a corneal scraping and sending the smear into the specimen into for culture and sensitivity tests. Next, please. So for the management part, corneal ulcer is an ocular emergency. So therefore, it will be urgently referred to the ophthalmologist, and culture is needed prior to the treatment. But the mainstream of the treatment will be topical antibiotics, and is started, and it is done to prevent the corneal ulcers to progress with complications, as I have listed on your right there.
So it depends on the infective agent. We do this corneal scraping to detect what is the agent. Now, bacterial, different from viral, different from fungal, have different clinical signs that make you suspect. More likely it's bacterial, more likely it's viral, more likely it's fungal. Fungal will have the ring-like opacifications and then the satellite lesions and all that. The viral will have the dendritic-like appearance and the herpetic type. The acute bacterial will be more fulminant, more ugly, having hypopyon levels and all that. So it depends on the causative agent. You don't say cover with antibiotics only. You have sometimes to cover with antiviral or antifungal. And this is the idea why we do the corneal scraping. We need to find what is the causative agent. In general, as a GP, general physician, you see opacification in the eye, you suspect corneal ulcer, and let's say with the history, contact lens user or something like this, yes, you need to refer to ophthalmology as an emergency case. Some causes like Pseudomonas aeruginosa can eat the whole cornea within a couple of days or 1 day sometimes. Hours is mattering to us because this ulcer can lead to scarring and to permanent complications that we cannot deal with in ophthalmology except with, let's say, the definitive penetrating keratoplasty. But why to reach to such level while you can treat with medications can? Okay, next.
That's all.
One more for corneal ulcer. How you differentiate corneal ulcer and corneal scarring? So usually corneal ulcer, we say is infiltrate. Corneal scarring is just scar. Okay, so the infiltrate will be fluffy, the edge, the smelting of the corneal stroma, versus the corneal scarring. You usually don't have all these. If you usually don't have corneal melting, and you don't have usually don't have the epithelial defect as well lah. But sometimes it still can have epithelial defect, but there's no corneal melting. That's the most important one. Okay, I think there's two things that you need to differentiate in outside, especially when you're doing your GP or any non-ophthalmology. What you need to differentiate ulcer and scar. Okay.
Yeah. One more is the corneal ulcer will have acute presentation. Corneal scar will have a chronic presentation.
Yeah. Sometimes
Okay.
corneal.
So thank you. Yeah.
sometimes corneal scar is
Go ahead.
presented with a history of trauma.
True.
Yeah.
True. Right. Thank you very much, Dr. Oyi, and thank you all. Thank you all very much. I think we did cover as much as we can. We are already out of time, and thank you for all the presenters. And sorry and forgive us that we didn't give the chance for those who prepared the other topics that we just didn't have time to present. But please read thoroughly about all these topics, and you are more oriented on the importance of all these topics. I wish you all the best, and I hope that we benefit from this session. Thank you all very much. Thank you very much.
Yeah, all the presentation is very concise, but we
Yes.
lack of time, so we just focus on the most important and trauma part lah. Okay.
Yes.
Right.
Yes,
Good
we
job,
try to
everyone.
cover as much as we can with this 1 hour. Okay, so with this, I think we can end the session. Thank you very much, Dr. Oyi, and thank you all. Thank you to all the students. Thank you very much. Thanks.
Okay, thank you, Ali. Thank you, everyone.
Thank you,
Bye-bye.
doctors.
Thank you, doctor.
Thank you, doctors.
Thank you, doctors.
Thank you, doctors.